One.
Good evening, everyone. We'll be starting shortly. We're just going to allow a minute for more participants to join. It's a pleasure sharing this evening with you and with Desi, who is not just the expert in his field, but the humblest and most excellent person we know. So thanks for joining us, Desi.
My pleasure.
All right, so I think let's not waste any time. I want to welcome you on behalf of the Paedodontic Society of South Africa, as well as SADA. We want to thank you for taking the time and sharing the evening with us. We hope that you will enjoy it and that you will take much to your practice. It's my privilege to announce our speaker for tonight, Dr. Desi Moodley, who completed his PhD in restorative dentistry at the University of Western Cape on dentin bonding agents. He's also currently studying for his second PhD on stem cells in regenerative dentistry. He completed his master's in dental science at the University of Stellenbosch, as well as his postgraduate diploma in aesthetic dentistry, cum laude. He is the winner of several awards, the Hutton Award from the IADR, for the best postgraduate research, the Lever Pons Scholarship, as well as the Pye Scholarship on his work on cytotoxicity of dentin bonding agents. He was awarded Best Outgoing Undergraduate Dental Student with gold medals for prosto, dental anatomy, pharmacology, and dental pathology. He is also a fellow of the International College of Dentists. He is the author of numerous scientific articles and the editor of the book Cytotoxicity of Dentin Bonding Agents. He was a private practitioner in East London and a senior lecturer at the University of Western Cape. But currently, he's flying the South African flag high as the head of clinical and scientific studies at the Smile Education Center in Austria. Desi, thank you so much for joining. Your knowledge and your experience, we miss you in South Africa, but we look forward to the lecture.
Thank you. Thank you so much, Nicolene, for that introduction. Always good chatting to you. Nicolene, for today, I thought I'm going to be talking firstly about the need for pediatric crowns. And that's just a couple of slides. This is will be consisting mainly of a review of literature. So a couple of systematic reviews that I'll talk about. And then I'll move on to some of the crowns or pediatric crowns that we have currently in use. This is more textbook style, showing you the step-by-step and advantages, disadvantages of these crowns. And then I'll move on explaining the science and the chemistry of the hybrid glass crowns. And finally, we'll look at some clinical cases. So that's basically the menu for today for me. But before I start, Nicolene, as you're aware, that this lecture was scheduled last month. And your time, South African time, was 7 to 8:30. And last month, our time at that time was 6 p.m. to end at 7:30. But rescheduled now. In the meantime, we moved our clock 1 hour forward with the daylight saving. So now my lecture starts the same time as you, 7 p.m. to 8:30. Of course, I don't have a problem giving the lecture till 8:30, but it runs straight into our 8 p.m. curfew. So if I get caught with the police, you or Marilise need to make a couple phone calls tomorrow to get me out of jail. Is that fine, Nicolene?
Well, we will do that for you, Desi. I'm so sorry to keep you out.
No, it's fine. We didn't realize the curfew was in place when we did the time, but I think it'll be fine. I don't think it'll be okay.
Can I just also mention, Desi, I forgot to ask the participants, any questions can be posted in the Q&A box at the bottom, and we'll address it at the end.
So, okay, Nicolene, I was only joking about the police here. I think it will be okay. But anyway, the curfew is on at 8 p.m., so that is part of it. Anyway, so we look at review some of the systematic reviews on restorations versus pediatric crowns, and why do we need pediatric crowns? Okay, so just a couple of slides on that. So the first was by Dawson et al. He has shown that roughly between 60 to 70% of restoration done in primary molars needed to be replaced or retreated within 3 years. Then another study by Erickson showed that 77% of amalgam, that is large amalgam restorations, needed some further treatment, compared to crowns that only required about 21%. So there's a big difference between amalgam restorations or restorations versus crown teeth. And not only that, it's the additional time spent. And this is most important, I think, for me, when it comes to pediatric dentistry, is you want to spend as little time as possible in the chair doing treatment for the children. So then the question now we need to ask ourselves, are we placing too many larger restorations instead of crowning the teeth? Okay. So we looked at this other study, looking at survival rate and replacement rate. So done by these two guys, E&D, and they have shown that crowns prove far superior than multi-surface amalgams in both lifespan as well as replacement rate. So with regards to survival rate, pediatric crowns lasted roughly about lasted right up to about 8 years, and that is about 83% of the crowns, compared to amalgam restorations that only lasted up to about 1 year in 80% of the cases. Okay, so when we looked at a 4.5 year survival rate, the amalgam restorations dropped to about 40%, compared to pediatric crowns that were at least about 90% survival rate. In terms of replacement rate, we looked at, there's a big difference in terms of this. 6% of the pediatric crowns needed to be replaced compared to almost 60% of the amalgam restorations. So in view, of course, this literature, and there's other literature as well available. In view of this literature that's available, we need to then reconsider in terms of placing crowns or large versus large restorations for a tooth that we think that the restoration will fail. Or in terms of extensive caries. Do you think that the restoration will last longer than the crown, or should we just place a crown and that's it, the patient doesn't need to come back? Also, in terms of secondary caries or extensive decalcification around a restored tooth, should we not just go straight for a crown? So again, with pulp therapy and endodontic procedures in primary teeth, perhaps crowns may be the answer rather than extensive amalgam or composite restorations. Of course, crowns work well in space for space maintainers, as well as for developmental defects such as amelogenesis imperfecta, dentinogenesis imperfecta, and other developmental defects. So now let's look at some of the pediatric crowns that are available to us, and I'll go through the procedures as well as advantages and disadvantages of some of these crowns. So the first we look at, and that was taught to us as undergraduate students, the age-old stainless steel crowns, okay? These were, the advantage of this was manageable treatment time. They lasted as long as the tooth was in mouth, most cases. And it functioned well because of the soft metal. It functioned quite well in the mouth. It required a little more extensive preparation. We needed to go subgingival for sure. It is, of course, not aesthetic. There's no fluoride release. And sometimes, quite often, there may be plaque accumulation, especially around the gingival areas. And the same goes for the preformed metal crowns as well. They're not aesthetic and also needed to be subgingival. So let's look at now the preparation for the stainless steel crowns. We needed to remove at least 1 to 1.5 millimeters occlusally, and then we also need to go subgingivally. So this is quite important that we need to go subgingivally because of the retention. The way the stainless steel crown is retained is it needs to go and snap into this sort of the buckle or the bulge in subgingivally. So a question that's I'm asked quite often is, what about the nickel allergy with regards to our stainless steel crown, considering that stainless steel crowns have about roughly 8 to about 13 or 14% nickel. So nickel allergy is a common problem. We all know that. And there is always a risk of sensitizing our patients if we continuously expose them to some nickel containing appliances. Okay. But of course, what does the literature say with regards to our stainless steel crowns? Is it safe or not? So this was a study done recently and published in one of the pediatric journals. They assessed the amount of nickel that's coming out of these dental appliances. Okay. So they wanted to evaluate how much of nickel or chromium that comes out of the stainless steel crowns. So their results found that it is well below the average dietary intake. So it is much below. Of course, there is some coming out, but it is below this. So the conclusion of this study was crowns used today have a very low potential for causing any untoward reactions. So in other words, these stainless steel crowns are fairly safe with regards to nickel coming out. Okay. But in spite of this, all or most of the instructions for use for stainless steel crowns would have some precautionary statement. Allergic reaction may occur, so you need to be aware of that. And of course, there are some articles also published on that. For example, this article was published fairly recently in the Journal of American Medical Association, okay, where they found that there was some reaction around the lips, as well as the gum showed some inflammation and edema. So there are some articles are available to show there's some reaction towards the nickel allergy. Another article, this is an article that showed a delayed hypersensitivity reaction to a stainless steel crown. And this article appeared in the Journal of Clinical Pediatric Dentistry 2012. So it's fairly recent. This reaction occurred roughly about 2 weeks after placing the crown. So there was an initial probably sensitivity towards the nickel, and then the reaction took place. So nickel allergy is there. Of course, the statement is that in the systematic review that it's safe to use. But dentists should be aware that it's a possibility. So the next type of crown is the aluminum veneered tooth color. So because of this drive towards aesthetic dentistry and we cannot place stainless steel crowns in the anterior region, we try to cover the metal with some aluminum or some white type or more aesthetically pleasing material. The problem with this was that it lacked the strength, the bonding strength. So they would always chip, and quite often in the gingival area or the cervical margin, it can cause some inflammation because of the roughness due to this chipping. So it wasn't that popular. Then, of course, we had the strip crowns or the polymer crowns. These are quite flexible. They're easy to, well, not easy to use. They're quite flexible in the sense that you could adjust it in the mouth much easier and just place composite into the crown or into this plastic pro-formed strip crown, and then place it or bond it in the mouth. It lacks strength, and of course it would discolor over time because it was just pure composite. So then now we moved on to the zirconia crowns. These are, of course, like the zirconia crowns that we use for adults, 1,200 megapascal strength, which is very high in terms of compressive strength. Of course, they're more aesthetic compared to the previous generation of crowns, but they're extremely, and I'm not sure if we need that 1,200 megapascal strength for children. The disadvantages of these zirconia crowns are that, firstly, the preparation itself is extremely difficult. You need to you are required to remove a lot of tooth structure. And of course, it is very hard, the material. It's quite expensive, and the preparation itself is not easy. It's very difficult. So we'll look at a little bit about the zirconia crowns and the preparation itself. So we need to remove at least 1.5 to 2 millimeters occlusally, which is quite a bit, and there's a chance of iatrogenic damage or pulpal exposure. We need to also remove interproximally. There shouldn't be any undercuts, because the crown needs to slip in. And remember, zirconia is extremely hard. You cannot adjust in the mouth. This is the step-by-step guide. It comes with a pink sort of a trial, a crown that you can, in terms of sizing, or a sizing guide. Once you've got the right size, then you can choose that type of crown that you want to use. And 1 to 2 millimeters occlusal reduction. You need to go at least 1 millimeter subgingivally. And the reason you need to go subgingivally, because of the height you need to get down, you cannot adjust the occlusion otherwise. And we will talk about the occlusion now. Interproximately, there should be no undercuts whatsoever, because the crown will not slip in. Right, so once you've got that, you need to go in subgingivally. And as I said, once you have to go subgingivally, and the reason for that is, if you do not go subgingivally, the height of the crown will be too long. So it's going to cause a hyperocclusion. And what they say in their instruction is that if you have hyperocclusion, the only way you can get rid of this, or if the bite is too high, in other words, you have to adjust the top tooth. This to me doesn't make sense. So if you check the occlusion and the occlusion is too high, the only way you can correct this is by adjusting the top tooth. Because you cannot cut or adjust the zirconia crown. It's too hard to cut it with a diamond bit. So you have to cut it. And of course, if the mother is watching you, she's going to tell you straight away that there's nothing wrong with my top tooth. Why, or my child's top tooth, why are you doing that? So, but that's one of the big issues that I have with regards to zirconia crown, is that you need to, in terms of occlusion, you need to adjust the top tooth. If you don't get the occlusion right, that is. Okay, so we need to do the top tooth. And also the manufacturers of this crown has realized that this is a problem. And in the instructions, they have clearly stated there, if the tooth is in hyperocclusion, the opposing tooth needs to be adjusted. To me, this is illogical. It doesn't make sense in the industry. There's nothing wrong with the top tooth. Why should you adjust the top tooth if you have caused an error in your restoration? So other common problems with regards to zirconia crown preparation, again, you have to go subgingival. You have to have a feather edge and no ledges or undercuts. Otherwise, the crown is not going to slip in. Remember, the zirconia crown is so hard. There's no forgiveness. It does not forgive. It cannot bend or there's no resilience whatsoever. You have to go 1 to 2 millimeters, and this is the only way you'll ensure that the crown the height will be in occlusion. Otherwise, it's going to be in hyperocclusion. The other problem is, because of the bulge in the cervical area, you need to get rid of that. So you need to cut quite a bit of tooth structure. For me, is when you're preparing this, it's almost the same as preparing a crown prep for an adult with say a porcelain fused to metal crown. So you need to do quite a bit of tooth reduction. The zirconia crowns cannot be adjusted. The only way you can adjust it is to do tooth adjustment. And the more you do on the tooth adjustment is you are removing good tooth structure. The buccal bulge as well needs to be removed. So, and interproximately, you need to have this taper. Otherwise, the crown is not going to sit. So it's quite difficult. Quite often, you may land up with quite a big bloody field in the mouth because you're going so far subgingivally. And remember, if it doesn't fit, then you have to go deeper and deeper into the subgingival area. This just causes more bleeding. So these are some of the issues with regards to zirconia crowns. And again, it needs to be tapered. Right. So because of this, the stainless steel crowns, they work well, but of course they're not aesthetic. Zirconia crowns on the other end needs quite a bit of, they're not minimally invasive. They require quite a bit of tooth reduction. So for me, zirconia crowns are a bit too aggressive when it comes to tooth preparation. So because of these two extremes that we have on either side of the spectrum with regards to crowns, Edelweiss has come up with their own crowns. And the rationale behind Edelweiss pediatric crowns was to have a crown that has the aesthetics of natural enamel. That's the first thing. Then they wanted it to be strong enough to be almost like particle for ceramics. You don't want to be strong like zirconia, which is 1,200 megapascals. You want it to be roughly about 500, 600 megapascals, which is similar to your EMAX or lithium disilicate. Then you want to have a little bit of elasticity. That is, you want it, the modulus of elasticity to be, or resilience, similar to denti, okay? Then you want to have a crown that you will do as minimum invasive preparation as possible. You don't want to remove good tooth structure just to place a crown in. And the preparation should suit the problem, which is the decay, not be made to suit your restoration. So what we do with other restorations is we are like amalgam, we extend it to prevent it coming out. Same with the zirconia crowns. We prepare so much so that it can seat in properly and doesn't come out, which is too aggressive. You want a crown that you can adjust in the mouth. Should you need some occlusion to be adjusted, you can adjust that crown easily. You don't want to touch on the opposing tooth. And then you want to be able, should it crack or chip, you want it to be able to repair it chairside. So in the mouth itself, you want it to be easily repaired. So this was a rationale when Edelweiss looked at coming up with a pediatric crown. And this is what the Edelweiss pediatric crown looked like. So they have almost a similar natural anatomy as the child or deciduous tooth. This is what it looks like, upper and lower jaw. And you can see the anatomy is very much similar to natural teeth compared to, say, the zirconia crown, which is very much on the occlusal surface quite flat. And the reason they make those teeth quite flat is because they don't want it to be in hypoocclusion. So the anatomy is not so good. Yeah, all the crowns are made supragingivally because you don't want to go into the subgingival area. So all crowns are supragingival. Again, in the lower jaw, they all look supragingival with enough area here for you to prepare. This is what it looked like when it goes into occlusion. That's from the buccal side, and then from the lingual side, you'll get perfect occlusion. And there's no fear of not getting the occlusion right, because this is very easy for you to adjust in the mouth itself. So where does this concept of hybrid glass come about? And what is this concept of hybrid glass? And also, where does it fit in terms of the spectrum of materials that we have? This started at the University of Geneva by these guys here. And what they did was through a process of laser sintering and vitrification. So sintering means that you're taking two solid particles, fusing them together, but without melting it. So it comes from ceramic technology. So what they've done is taken glass particles and fused it together so that you have a solid glass particle. And vitrification comes from the word vitrium, a Greek word, which means to be glass-like. So what they've done is then coated the surface with fine glass particles. So that's one of the reasons why you need to roughen the inside of the crown, is because the entire thing is glossy and glass-like. But we'll go over that when we discuss this step by step. So this is what it looks like. This is from Geneva University. It's a smooth inorganic surface, and there is a distinct vitrified layer that's present there. So they've shown that the laser sintering and vitrification process worked. This is a SEM that we did, or I did, and at 7,000 magnification, showing that the glass particles are fused together with very little resin present. This is again from University of Geneva. What it has done through this process of vitrification and laser sintering, it has moved the physical properties of the material to that close to particle filled ceramics. For example, the compressive strength is 550 megapascals. And Emax, which is lithium disilicate, is 600 megapascals. So if you compare the Edelweiss, it has taken the physical properties and upped it to very much closer to your particle filled ceramics. But you don't want to go too high compared to Zirconia, which is too strong. So the compressive strength is about 550 compared to Emax, which is 600. But what is quite important is that the flexural modulus, or the modulus of elasticity, is 20 gigapascals, which is close to dentine. So you want to keep that little bit of flexibility. Of course, there's no shrinkage because it's preformed. So if you look at the spectrum of materials, we have glass ceramics on one side. That is mainly a feldspathic. This had the best aesthetics. But the problem with this material was it wasn't strong enough. So what they've done is they've reinforced this glass ceramics with alumina or lithium disilicate to get the reinforced ceramics. So then the strength increased. But with that, this material was still a bit brittle, so it would crack and chip. Okay, and then of course, composites on the other end was not strong enough and didn't have the aesthetics of this, but it had a little bit of resilience and you could repair it. So ideally it would be to have a material that can incorporate all three of these properties. So if you look at the elemental analysis of the Edelweiss pediatric crown, it consists mainly of silica and your barium glass. So that is representing your ceramic or your pure glass ceramics or your like feldspathic. So that gives you the aesthetic properties of the Edelweiss pediatric crown. Then they've included aluminum oxide, and that gives you the strength, and that has taken the strength of the material close to your particle filled ceramics. A little bit of resin is maintained here, and that's in the form of carbon there, and that is less than about 8 to 9%. And the reason the resin is there to allow for this resilience, so that you could adjust it in the mouth, number one, and number two, you could repair it in the mouth. So they kept these three as the main components to have the best of three worlds. The big advantage, of course, it has zinc oxide, which we know is antibacterial, and fluoride. Of course, we don't know, well, I don't know how much of fluoride is being released, but the point is there is fluoride in the material itself. So that is the elemental analysis with regards to having the three phases of the Edelweiss pediatric crown. So in terms of the sizes itself, how does it come? It comes as small, medium, and large. And in terms of how did they get the measurements? If you look at with zirconia crowns, the mesial distal, we just take this for an example, ranges from 6.12 millimeters to 8.35 millimeters. That's a mesial distal of a zirconia crown. Edelweiss, if you look at the medium, is 6.4 millimeters. So there is a big difference between the two. It's almost on the lower end, almost between 0 and 1 of the zirconia crowns. But if you look at the Wheeler's measurement of average, a table of measurement of the primary teeth of man, I don't understand why they wrote man, they should have been primary teeth of child maybe. In millimeters, so it's smack bang 6.4, 6.5. So it's smack bang in the average zone of, according to Wheeler's. The small is about 8% lower than the medium, and the large is 8% above. So the measurements are smack bang in the average of measurements according to Wheeler. So let's look at now the indications of when can we use the Edelweiss pediatric crowns. So we'll go through this and then we'll look at some clinical cases as well as a step-by-step on how to use it. Of course, in rampant caries, this will be an ideal case. We looked at systematic reviews where large restorations would fail, means patient coming back. In terms of caries, large restorations that have broken, this would be ideal situation with regards to pediatric crown. This was a case that I did in Bulgaria. They invited me over to speak and then to treat this patient. This is an ideal case for discolored tooth. You just need to shave off the enamel and then replace it with an opaque dentine shade composite and then step on in, and a perfect result. Of course, with pulpotomies and pulpectomies, this would be an ideal situation for Edelweiss pediatric crowns. In terms of erosion, we're starting to see lots of cases of this erosion with children and pediatric crowns. In terms of Edelweiss pediatric crowns, would work quite well because you need minimal preparation. So if you're going to think of putting a zirconia crown, you need to cut quite a bit. And why damage so much? Already the patient has lost a lot of tooth structure. Try and conserve as much tooth structure, just simply place the crown over. So Edelweiss pediatric crown would work quite well with this in this regard. In terms of enamel opacities, you can simply place those Edelweiss crowns on there. Enamel defects or dentin defects is always a problem with regards to retention as well as in terms of bonding. And we'll show you a few cases where we've done using the Edelweiss and how well that works. So let's look at some of the clinical cases. Right, so this was a case that was done by the Children's Dental Center, and that was before and after. This case we published in the Dental Tribune EU edition. So if any one of you needs that article, with pleasure, you can just send me an email and we'll get that article to you. So this was a case that was done. This was another case that he did. This was immediately after post-operatively, so that's why there's a little bleeding in there. But generally, these buccal restorations are very difficult with composites. They don't stick that well. Ideally, would be just to slip a crown in there, a pediatric crown. It's an ideal case for that. Again, large restoration. These restorations may fail. So that's what it looks like before and after. A perfect situation, and you know this crown would last the lifetime of the tooth itself. So they're quite durable and a nice, good end result. Again, this is large pulpotomy. Oh, sorry, he did endodontics on this, yeah, and then place those crowns on those two teeth and perfect results. This with dentinogenesis imperfecta, that's in the past, the only way we could treat it is placing stainless steel crowns in front. Of course, you can't go with stainless steel crowns in the, stainless steel crowns at the back. We can't go with stainless steel crowns at the front for aesthetic reasons. So we had no option but just to leave it like that. Okay, a friend, a pediatric dentist in Marseille in France, this is what he did. Placed 6 anterior Edelweiss pediatric crowns, and that's what end result that he had. This was another case that we did just before the actual launch. This was done about 3 or 4 years ago, before the actual launch of the Edelweiss pediatric crown. This case was done just so that, in terms of testing, to make sure that it's durable and it worked well. So this was the patient. This is what she is now, and after many years, that crown was still in place. So a step-by-step would be, of course, you can place a retraction cord if you like, etching the enamel or dentine, and then bonding the tooth, placing a bonding agent on the tooth itself. That is a traditional bond that you'd use. On the inside of the Edelweiss crown, you need to roughen it and place a special type of bond. The reason that type of bond needs, it's almost like a primer bond that you need to place into the crown. And then application of the Edelweiss cement, which is mainly a composite type of cement. And the the reason we like to use this composite is it has the same composition as the crown itself. So it acts like a monoblock system. And position that in place, remove the excess cement, light cure that, and final finishing and polishing. So the steps are pretty much, it's almost like doing a composite restoration. So the preparation design itself, how do you design that? So what the Edelweiss has an even thickness of 0.5 all around. So even the margin is 0.5, but it's very flexible in the sense that you can adjust it to whatever you want, because it's very easy to adjust in the mouth itself, or you can even adjust the crown before placing. For example, if there is a MO only, you do not need to cut the distal cavity or a distal wall just to place the crown. You can slip the crown or cut the crown in half or 3/4 and just do a MO only and leave the distal wall. The idea behind that is to keep it as minimally invasive as possible, and again, not to destroy any unwanted or unnecessary tooth structure. Why cut unnecessary if there's nothing wrong with the tooth structure? Why cut it simply because we want to place a restoration? It's not logical. So the bonding system works using the Edelweiss bonding system itself, or you can use a resin modified glass ionomer cement if you prefer. Again, using the Edelweiss bonding system, which is like a primer, is just to make sure that it primes because it's pure glass, you want to prime it a bit, and then using the composite, Edelweiss composite. And as I said, that the composite and the crown itself has the same chemical composition, so it acts like a monoblock system. And by acting like a monoblock system, what actually happens is it strengthens the actual restoration itself as well as the bond. So we do not have a demarcation between the resin and the restoration. That's number one. And number two is you wouldn't get any wear or discoloration at the junction between the restoration and your cement. So there'll be no cement line as such. So with the Edelweiss Paediatric Crown Bond and Composite, they all have the same ingredients or components. So it acts as one system. Again, of course, you still can use a resin modified glass ionomer if you prefer. So with the Edelweiss bonding system, again, University of Geneva have tested it, and they found, of course, no micro leakage between enamel and dentine sides as well after thermocycling and putting it on a chewing simulator. So the bonding system works well. So if it fractures or cracks, how easy is it to repair? Pretty straightforward. Simply roughen the area, apply your Edelweiss primer bond, and then blow dry that and light cure it. And then over that, you apply your Edelweiss composite, and then, of course, light cure and finish. A question that I get quite often asked is, can I apply some other composite? You can, it's not a problem, but why do you want to? The composition of this is the same as that, use the same. You're going to use that for cementing in any case, so use the same composite. It makes more sense. How do you apply, or how do you place the crown after placing a composite into the crown? How do you place it? I found that if I place it directly in the vertical direction, it sometimes not that easy because of the bulk or the bulge on both the buccal and the lingual side. So I find it much easier if I place it on the buccal side and then tilt it over onto the lingual side. So it just almost slips over your prepared tooth or the crown of the tooth. So it just simply tilts over, and then you can remove excess, and that's just experience. In terms of placing the crown, because it's minimally invasive, you don't want to remove a lot of tooth structure. In that way, it's just much easier to place a crown over. So you actually tilt it over onto the lingual side, starting from the buccal. Another big advantage of the Edelweiss Paediatric Crown is that you can individualize it. You can modify it to whatever you want to do. And the way to do that is, for example, let's say there is a space between, if you place your crown, there's a space between that and the neighboring tooth, and you don't want to leave a gap interproximally. You want to close that gap. So all you need to do is roughen the crown, and then you, of course, you can etch it or just rinse it off. Apply some of the Edelweiss bond over that, light cure that, and then place some of the Edelweiss enamel composite to the length that you want to close that gap. So then you light cure that, and now you'll notice that you've got a little bulkier mesiodistal crown. And of course, now this will close that gap mesiodistally. So a very big advantage. And you simply need to use 2 cups, and you will get a final polish that will not be rough to accumulate any plaque. So that's pretty straightforward in terms of closing up a gap or making a crown a little bigger. You can also use one of these polishing wheels to get a better polish in the end. So you've increased the length of that, the mesiodistal length, by simply adding more composite on either end. You can also add, if you want to, some special effects. For example, if you need to do some halo or whatever effects you want, that's pretty straightforward. You can just tint on the inside, because the Edelweiss crown itself is very translucent. It's almost like natural enamel. So whatever color you put on the inside will shine through. So if the tooth is highly stained or discolored, like the one that I did, I put in a dentine shade composite. So that completely blocks out any discoloration from the inside, and you will get it almost mimics the dentine, and then this will mimic the enamel. So it's almost natural looking. This was another case that I did. I think it was in Prague or Estonia. The mother was concerned about the mesial caries, and there was a little bit on the gingival area. So of course, mesial distal caries are very difficult to do, and those composites are not easy and they don't hold so well. But she wanted it to look much better. So what I did here was, and I didn't want to place the full crowns because there was nothing wrong with the palatal side of those teeth. So what I did was I individualized those Edelweiss pediatric crowns to make them into veneers. I converted those crowns into veneers. So what I did was, you don't need to do it on a model. You can do it chairside. I removed the palatal aspect of those crowns. So I simply then just placed them as veneer, treated them as veneers. I removed the caries, mesial distal, and a little bit on the buccal side, and cemented them. So they act as veneers for the children. So those same Edelweiss crowns were modified to veneers. So it is minimally invasive. You can adjust it in the mouth. With regards to amelogenesis imperfecta, is always a problem, especially with bonding. I found that some articles state that sodium hypochlorite 5% tends to improve retention or the bond strength. You vigorously use 5%, liberally 5% sodium hypochlorite for 1 minute, rinse off, and then etch, and then bond. So it seems to be working well, getting better results using sodium hypochlorite rather than just going straight for etching and bonding. This is a case done by Nicolene. She sent me these pictures immediately after doing them in theater. This was preoperatively, and that's what it looked like after the case was done. So fairly good result. It's quite easy to do because you can adjust that crown to whatever you want to. You can even adjust mesial distal gingival contours you can do. This was another crown that she placed on there. And so you can see it's quite easy to use and not difficult as well. So Nicolene, well done. That was excellent. Thank you so much for those pictures as well. So with regards to, this is quite a big thing as well, yeah. MIH, it's about incidence ranges from about 4 to 25%. So it's quite a high incidence where the molars and the centrals are affected. So how would we do the molars then in terms of being minimally invasive? You can't use the Edelweiss pediatric crown because they are the permanent molars. So the Edelweiss occlusion VDs you simply remove the affected area and cement this the same way you would do for the pediatric crowns. You would use occlusion VDs. And then you also, for the anteriors, you could use the Edelweiss veneers. So this was done where you do minimal invasive. You don't need to remove a lot because already there's a lot of tooth structure missing. Just clean up that area and place the Edelweiss occlusion VD over, and that will hold for a long time. So we're going towards minimally invasive, try and preserve as much tooth structure as possible. The last case that I want to show you is a case that we did about 2 years ago. A child slipped the swimming side of the swimming pool and cracked the tooth. So she came in as an emergency, and we thought we'll place the Edelweiss pediatric crown. So this is what we did. Of course, we did a first color shade match, and then we adjusted incisally so that we could get a nice, good fit. And that's one of the big advantages. You can adjust the crown to whatever height you want to, so you don't have to cut or go subgingival. So in this case, we stuck supragingival. We prepped the crown, and then we etched and applied our bonding agent. Light cured that, applied, placed some of the Edelweiss composite cement in the crown itself, and then place that in the mouth, and then to remove any excess. Remove all excess material, then light cure that in all directions for 20 seconds in each direction. That's light curing. And then final adjustment. So we thought we will try and get these notches and mamelons to show. So we created that to match up with the adjacent or the alternative tooth on either side. So we did the same notch there. And I mean, that looks almost natural-like and looks almost the same. We could have, if we wanted to, even made this area a little darker by using, say, an A1 composite shade and A0, yeah, and then you would get it to look exactly like this. But that's a possibility that you could do. You could adjust to whatever you want to, and then the notches were quite easy to make. So that's a flexibility that you have with regards to the Edelweiss pediatric crown. So that's what she looks from the when you take the photograph from the top. We still made that notch there for her. And this is what she looks like. And a very happy patient. So she was just bubbling with this because she was just thought that she's going to have a gap. Her main problem was she was worried that when she goes back to school, this was over the December holidays last year, just before the pandemic. And she was worried that friends are going to tease her if she loses that tooth. So she was very pleased that she got this result in the end. So, in conclusion, the Edelweiss pediatric crown is basically a single glass phase. That's your hybrid glass, where they fused all the glass particles, that's silica and barium glass, into a single phase. And that is mainly for the aesthetics. So it resembles that of your pure glass ceramics. Then we have aluminum oxide was added to this. Now this for compressive strength, and this now resembles that of particle reinforced ceramics. So you have the best of both worlds. You have the aesthetics of your pure glass ceramics and the strength of your particle filled ceramics. But at the same time, you still have some resin for some resilience or elasticity. So you could repair in the mouth or you can adjust in the mouth. So it makes it much easier for you to place this crown and also to adjust, and you can make it into veneers as well. And then finally, of course, you have, and very important to me, is the zinc oxide nanoparticles as well as the fluoride. And this is quite important because, especially with pediatric cases. So, and how is this possible? It mainly became possible because of the laser sintering and vitrification process, where they've fused the individual glass particles into one single mass of glass, and that's how you got the aesthetics. Okay, and by adding aluminum oxide, you could get the compressive strength. So in terms of the technology itself, is combining all three technologies, the glass ceramics, the reinforced ceramics, and the resin technology into one single Edelweiss pediatric crown. So that's what the Edelweiss pediatric crown in terms of technology incorporates. So that was what we did in the past with the metal crowns and stainless steel crowns. We are no more moving in that direction. We want to move minimally invasive. And of course, try and be as natural looking as possible. Try and keep it minimally invasive and easy to adjust in the mouth itself. A pediatric dentist from Germany, after using these crowns, had this to say. He said that as a pediatric dentist, once you experience the versatility of the Edelweiss pediatric crown, you will never want to be restricted by other crowns. And the reason he said that is because he could do whatever he wanted. He could be minimally invasive. He could cut the crown in half. He could make it into veneers. He could adjust it whichever way he wanted. He is not restricted in any way in terms of preparation guidelines, but restricted more in terms of caries removal rather than your restoration that you need to suit in terms of your preparation. So I need to, in conclusion, of course, need to thank Nicolene from the Paedodontic Society for organizing this conference for us. And of course, SADA as well for the organization of this. They sent me some instructions in terms of preparing for this that was quite in detail. And one of the instructions that Melanie sent me was to make sure that my dress code was smart casual, but from the waist upwards. So said that I shouldn't stand up just as long as I'm looked smart casual from the waist upwards. Then, of course, our commercial sponsors for the evening, Wrights Milners and Chantel, that helped get this together. And, of course, Nico from Edelweiss that put all this together. So thank you very much for that. And thanks, Nicolene, for inviting me as well.
It's a pleasure, Desi. Thank you so much for the lecture. It's really informative. It's great to see new technology. I have quite a few questions for you. So I'm going to split it into clinical and then a little bit more towards some practical. Yes. So clinical, the three questions that came up. The first was, how do you manage gingival bleeding after preparation of any type of crown, from stainless steel to zirconia to a preformed resin? So how do you manage your gingival bleeding?
So we do it the same way that we do it for adults as well. Okay, so we use hemostats that we use, and we use a cords that we inject with hemostat, and in the same way as we would do with adult crowns. So it's not there are also, you can use paste also available that you can inject into the sulcus to manage bleeding, and once that stops, then we wash it out. But as I say, we do it the same way we do it with adults in terms of crown preps.
Okay, thanks. Then the next question was, can you use normal composite and bonding agents, or will it only work with the Edelweiss product?
Yeah, so with regards to why, the difference between the Edelweiss bond and so with in terms of dentine bonding agents, we have two portions. The one is a hydrophilic portion and one is a hydrophobic portion in one bottle. So, and the reason for that is the hydrophilic portion needs to go into the dentine, which is dentinal tubules, which is moist. Right, and that drags the hydrophobic portion from the top, and the hydrophobic portion then bonds to the composite. That's standard dentine bonding agents. With regards to the Edelweiss bond itself, we do not, just the bond itself, we do not have the hydrophilic portion because you don't need it. There's no tubules there. It's only the hydrophobic portion. And if you use your traditional or your conventional bonding agents on the inside of the pediatric crown, you're going to have this hema or hydrophilic portion in the crown itself. And that can cause, it also has water in it. They can be water traps and it affects the bonding. That's the first thing. Number two, it can also discolor, cause some discolor. It has a bit of a yellowish discoloration. We advise you not to use it. We want you to use, especially the bond. You should, I know, especially in Asia, the instruction didn't go so well, and they were using their own bond in the Edelweiss, and the crowns are coming out. And the reason for that is because of this hydrophilic portion that's present in the standard bonding agent. So you have to use, and you have to roughen it, and then use the Edelweiss bond on the crown itself. With regards to the tooth itself, you cannot use the Edelweiss bond on the tooth. And again, because it has only the hydrophobic portion, doesn't have the hydrophilic portion. So in the tooth itself, you need to etch like normal, and then you need to use your conventional bonding agent that you use, whether it's Scotch Bond or whatever, Clearfill or whatever you're using. And that will then drag the bonding agent in the tubules, and then over that you will bond your composite. With regards to composite itself, should you only use Edelweiss composite or can you use any other composite? We prefer to use the Edelweiss composite for the simple reason it has the same components. It has silica, it has barium glass, it has zinc oxide. So it has the same components. But I know many dentists have used their own composite, so long as it's either a hybrid composite or a microfill composite, a good quality, and it'll work. So regards to composite may not be effective, but the bonding agent, I think, is quite important. If you mix that up, then it's not going to work. And I know lots of dentists have mixed it up. They've placed the Edelweiss bond on the tooth. They thought they can use both bond at one go. It's not going to work. I can tell you, I can guarantee it wouldn't work. It must fail because you only have hydrophobic portion in one. Okay.
Okay, thank you. Our next question is from someone who actually tried the Edelweiss crowns already. And the dentist asked what they are doing wrong because they have cracked two of the crowns during cementation process. So they wanted to ask regarding that.
Yeah. So again, with regards to when you're placing it, that's why I got the slide there to tilt it from buccal to lingual. And the reason why it cracks in the middle, and I've seen a couple of cases and a couple of dentists told me about it as well, is if you place, especially with the Edelweiss composite, it's quite viscous. It's quite thick and quite hard. So firstly, you need to soften it and place it evenly around the inside of the crown. And if you exert pressure apically from the top to the bottom, it's almost as if it acts like a fulcrum in the center of the crown, and then it splits in the middle. Okay, because of the pressure and the composite is quite hard and firm, so it splits in the middle. And remember, the crown is only 0.5 millimeters thick, so that is why I prefer to go from the buccal and tilt it down. Okay, that's one of the reasons that it'll crack. The other case I had, a dentist called me. She placed the crowns, I think it was D&E, in theater, and then the patient in recovery bit and cracked the crowns. So the nurse in recovery, the recovery nurse brought the crowns back to the dentist in theater and said, in a hand, this is the crowns that broke. So then we checked what was the problem? You know, how did this break? So I said, did you check the occlusion in theater before sending the patient? She said, how can I check the occlusion because the patient had a tube in the mouth? So, of course, you should not, the anesthetist should put a nasal tube, not an oral tube. Okay, because if you got a nasal tube, you can't check the occlusion. So in this instance, she couldn't check the occlusion because she had the nasal tube. Sorry, the oral tube. You have to, I think, most anesthetists now will put a nasal tube in, do nasal intubation, and then you can check your occlusion. The occlusion also, again, is very important. And this is also with adult crowns as well. We only check static occlusion. And static occlusion is not enough. You have to check dynamic occlusion. That is a movement. You have to do the excursions to make sure that it's right, and then send the patient off to recovery. So those are the two main reasons. In my experience with regards to the Edelweiss crowns, there can be only two failures. The two failures would be, one is from a bonding point of view, and one is if it fractures. Okay, if the bonding if the bonding issue with regards to mixing up the bonding or not doing the using the Edelweiss bond on the tooth or vice versa, whatever, if you do that incorrectly, then it's going to come out. That's the first issue. The second issue is if it breaks or cracks, and that again is you have to check dynamic occlusion as well. It's not just static occlusion. So those are the two issues that I have only, or complaints that I had, and quite often we resolve it that way.
Okay, awesome. Thank you. Then we're moving on to some different questions. There's quite a few people asking for pricing of the product. I will ask Milnesh to send out mail regarding,
with regards to pricing, I think it's better, Marilis. I really don't know about pricing, so I just know the science part. So with regards to pricing, I think Marilis maybe. Sorry, not Marilis, Chantel. Sorry, Chantel may be the one to get hold of, or Nico. But I think probably Chantel may be easier to get hold of.
Okay, so I just want to say to the participants regarding pricing and the codes you can charge for the crowns. We will make Milnesh put the package together and try and send out a mail regarding that, so we can inform you how to get them and how to price for them. Also, there was a request that the crowns should be sold individually and not only in the kits, because then they can plan cases adequately and not necessarily need to buy the kit. So I'll address that concern with Milnesh as well, or just make the recommendation. Then there was quite a few people, and it's very interesting for me, who had the concern of the applicability in South Africa. So you know our situation here. I think the Edelweiss crowns are perfect for private practice, for aesthetically driven dentistry, and for people who can afford it. But I want to ask your opinion in general. Do you think there's a place for crowns in South Africa serving the poorer communities? Thinking of stainless steel crowns. Can you give your opinion on that, please?
Yes. You know, when preparing for this lecture, when I looked at restorations in terms of large restorations versus crowns, and I think how much of time we waste in terms of redoing restorations. I know when I was in practice as well, some of those amalgams, it's so difficult to do a MOD or a mesial buccal occlusal. It's because those things don't last. For some reason with children, they don't last that long. This, I think, will be, I'm not saying for Edelweiss, but crowns in general, will be an answer in terms of saving or preserving the tooth for its, in terms of its, as long as it's in the mouth, and you saving the child repeated visits to the dentist. So my opinion is it's not about which country or where you are, it's about the child and the tooth. I understand finances are issue but at the end of the day, it's what is the right thing for the child and the tooth and crowns. It has its place, and we've been underusing the crowns simply because we didn't have a proper crown available. Number one, and number two is we were it was much cheaper and easier because we knew about MODs and amalgams and things, so we could just place them. But I think this would be a reasonable option for large restorations. And I mean, Nicole, in some of those restorations, they're very difficult. They don't last. If you do anterior composites, it's a real battle. And also the children moving around, and it's not easy. So certainly it has its place. I understand finances are a problem, but if we just look at the child and the tooth, this can be the answer. It'll save a lot in terms of if state health does it and start placing these crowns. How much of orthodontics we will be saving in terms of not extracting those teeth. In the long run, there'll be so much to say. But I mean, you know that better than I do in terms of preserving baby or milk teeth and saving on orthodontics in the future.
Okay. All right. Thanks.
But I don't know your opinion on that. Yeah.
I have an interesting question. It's the last question. I think it's one of your old colleagues, because they wished you well and said it's so nice to see you again in the beginning of the Q&A.
What's his name?
Dr. Norman.
Are you allowed to say
Clement.
that? Oh, yeah. Okay. Yes. Yeah.
So he asked that he wants your opinion on the caries management principle, addressing caries as a disease and incorporating prevention and managing caries like that, how this fits in with crown placements in pediatric dentistry. If you can just tell how it fits together.
Okay. So yeah. So in terms of course, but just sidetrack a little bit before I answer that. I was in Philippines just before the pandemic, and I shared the platform with the pediatric dentist from New York University. All right, and we were just chatting before the Congress on and we were speaking, and there was someone else from Australia, Sydney. And we were talking about the Hall technique, the leaving the caries behind. And so I don't know if it's quite popular with you or what your opinion on it, but lots of them say that why remove a lot of caries, and the studies, I think it was a big study done in the UK where you can leave the caries and place a crown over and you'll be fine. This guy from New York says he does not teach the Hall technique. And if he is called to court in case of a litigation, he would testify against any dentist that's using the Hall technique. So I asked him, but why? Yeah, of course, yes, it's raising eyebrows, because you think to yourself, I mean, there's a big study done and we can use that in court to say the big study. He says, no way in medicine should we leave any decay or bacteria. It's not possible. It's not logical to leave some disease process in the mouth and try and cover it up with some bandage. So he says he will testify in court. So that was his opinion, but I thought I will share that with you. With regards to with regards to in terms of caries prevention, of course, yes, we need to prevent caries. It saves in the long run in terms of trying. Gone are those days where we just need to start to just leave the teeth to decay and extract. And it's so much of course. I was speaking to an orthodontist, and he says the biggest cause, and you may also know this, of malocclusion is extractions, is premature extraction of teeth. I mean, that's one of the biggest causes. If we caries manage those children at an early age, or prevent caries or prevent decay at an early age, we would save so much in the long term in any country as well. That's the same thing. We think that the crowns are expensive, but if we look at the big picture in terms of how much are we saving in terms of treatment and orthodontic and crowns and bridges when the child is an adult, that can all be saved if we prevent properly. So prevention is, I mean, it's I don't think it's an argument at all. We need to do it.
Okay. Now, I really want to thank you, Desi, and to the participants. We apologize that some of the slides went a little bit out of focus throughout the presentation.
Oh.
I think the live streaming from Austria was
really. I'm actually not even using Wi-Fi. I've gone on a LAN. Because I didn't want anything to go wrong with that. I am sorry about that, but I will speak.
No, it's fine, Desi. But we just wanted to mention to the participants, thank you for bringing it onto our attention. And I really want to thank all of you for sharing your time with us. If you're not a member of the Pedo Society, please join. We're doing great outreach projects. We're bringing new information to you. And we cannot run and function as a society without any participants and members. So please join if you haven't joined. Daisy, there was so many comments in the box saying that they miss you here and that it's so great to see you. You are a legend here. So thank you so much for sharing your time with us and your expertise. And I wish you all a wonderful evening.
Thank you so much. Also a safe evening for me, that I must make sure I don't get caught with the police.
Now, please don't get caught. Somebody also offered $25 to help get you out of jail.
That's good. I'll keep that in mind. But thank you so much. It's so good. Of course, it's SADA for me is always special. And Marilis also knows that if SADA invites me, I drop everything and to speak for SADA. It's always special. This is only a temporary thing for me, so it's not. South Africa is still I'm very close to, and I'm always home, and so I always enjoy talking for SADA, and thanks so much for all those lovely comments, and I miss all you guys. So please send me the message and email me. It'd be really nice to hear from the guys. Okay. And if you need any information as well, it would be my pleasure. Thank you so much, Nicolene, and we'll chat again.
Thank you. Have a good evening, everybody.
Thank you. Bye-bye. Ciao.